Good evening, friends. Thank you to all of you for joining in for another important episode of 4D, that is Detailed Discussion and Dialogue for Indian Diabetics. Today, we are very thankful to you for your continued patronage and support because with your support, we have been able to reach the 50th episodes. Yes, it is a 50th episode today, and I cannot thank all you participants for your active participations enough. So today we are going to be talking about a very important topic, that is chronic kidney disease in diabetes. Chronic kidney disease, that is kidney disease, diabetic kidney disease, chronic kidney disease. It's a very important complication, comorbidity in which develops unfortunately in large number of patients with diabetes. And we have had a lot of important advances nowadays in the management of chronic kidney disease with diabetes, and also in terms of preventing chronic kidney disease in the development of diabetes, because at the end of the day, if we can prevent a disease, there's nothing like it. So there are so many advances which have happened in last one and a half decade, through which we can diagnose people before they progress into an advanced stage of kidney disease, into an earlier stage of kidney disease or a diabetic kidney disease or a diabetic nephropathy, before they progress into that. And large number of patients who unfortunately have a curtailed life expectancy as well as a poor quality of life due to chronic kidney disease in diabetes, they can actually be benefited a lot with all the recent advances. And to talk about that, we have a very eminent endocrinologist today, Dr. Suchitra Yadav. Dr. Suchitra Yadav, she's an endocrinologist based in Jaipur. She's an MBBS, MD, DM endocrinology gold medalist. She initially worked as a senior resident in the Department of Endocrinology at Jaipur, and then as a senior resident in the Department of Endocrinology at Gangaram Hospital, Delhi, and subsequently worked as a senior resident in the Department of Endocrinology at SMS Hospital, Jaipur. She secured the 17th All India rank in DM Endocrinology entrance exam at NEET Super Speciality Entrance 2022, and also secured a second prize in paper presentation at Pericon 2017. So a lot of good credentials, Dr. Suchitra. We are pleased to have you here. Welcome to the show.
I am Dr. Suchitra Yadav, consultant endocrinologist at AMRC Park Hospital, Jaipur. So today we will discuss about diabetes and chronic kidney disease. So the prevalence of diabetes is 9.6 among adults aged 20 and above. In India, 1 in 11 adults is living with diabetes. The number of people with diabetes in India is the second highest in the world, and over 53% of the adults living with diabetes are undiagnosed, and 90 million adults living with diabetes. 1 in 2 adults with diabetes are undiagnosed, and there are 747,000 deaths caused by diabetes in 2021. The most common cause of CKD is diabetes. 44% of all the kidney disease are contributed by diabetes, with 29% contributed by high blood pressure and 18.4% other causes, with 7% of glomerular cause and 1.6% related to polycystic kidney disease. So the mechanism is due to hyperglycemia in the glomerulus. There is increased angiotensinogen, which leads to increased activity of angiotensin convertase enzyme, leading to increased formation of angiotensin 2, which ultimately leads to CKD. And also at proximal tubules, there is increased angiotensinogen, leads to increase in angiotensin 2, and ultimately contributing to CKD. So classification and screening of CKD, it is based on EGFR and albuminuria. Uh, EGFR more than 90 is stage 1. EGFR 60 to 89 is stage 2. EGFR 45 to 59 is stage 3A. EGFR 30 to 44 is stage 3B. And 15 to 29 is stage 4. And less than 15 is stage 5. Who and whom to screen in type 1 diabetes patients after 5 years of diagnosis, we have to screen yearly. In type 2 diabetes, even at the diagnosis, we have to screen, and then yearly. And what defines CKD? Persistent albuminuria more than 30 milligram per gram of creatinine, persistent decrease in EGFR less than 60 ml per minute per 1.73 meter square for 3 months, other evidence of kidney damage. Therapeutic strategies for diabetes management. Early initiation of combination therapy is an approach to achieve glycemic goals earlier and delay the deterioration of glycemic control with possible better preservation of beta cell function. Novel medication, they are used with diabetes, diet and exercise to control high blood sugar in adults with type 2 diabetes. They are DPP-4 inhibitors like sitagliptin, saxagliptin, elinagliptin, and alogliptin, and SGL2 inhibitors like canagliflozin, dapagliflozin, and empagliflozin, and GLP-1 receptor agonist. GLP-1 receptor agonists like semaglutide, they regulate and restore the incretin function. An SGLT2 inhibitor plus DPP4 fixed dose combination is a suitable option for type 2 diabetes Indian patients for the following reasons. They have safer, rapid, and sustained glycemic control, improves both insulin resistance and beta cell function, helps reduce body weight and blood pressure, reduce pill burden, and overall cost effective. SGLT2 inhibitors and DPP4 inhibitors in diabetes management. Dapagliflozin in combination with sitagliptin was well tolerated and led to clinically meaningful reduction in glycemic parameters and body weight that were sustained through 48 weeks of treatment. SGLT2 inhibitors and DPP4 inhibitors, they have synergistic combination. SGLT2 inhibitors decrease the plasma volume, decrease insulin resistance, they increase hepatic glucagons, and DPP4 inhibitors, they have renal vascular, they decrease the oxidative stress. Their mechanism of action is mediated by incretins. They increase the level of GLP and GLP-1. So the mechanism of action is synergistic. So they have synergistic effect on hyperglycemia, and they decrease albuminuria, decrease systolic blood pressure, and there is very minimal hypoglycemia risk with this. And also DPP4 inhibitors are weight neutral, and SGLT2 inhibitors, they cause weight loss. So the combination have synergistic effect. Benefits of SGLT2 inhibitors in a liver, they decrease hepatic glucose output, they decrease ketogenesis, they decrease steatosis. In cardiovascular, they decrease arterial stiffness, they improve endothelial function and decrease the risk of heart failure. In pancreas, they increase glucagon and decrease insulin, and they decrease glucotoxicity, they cause weight loss. And in kidneys, they restore the tubuloglomerular feedback, decrease oxidative stress, decrease fibrosis, increase uricosuric, and lipids, they improve lipolysis, they decrease fat mass. So across various trials like DAPA-CKD, DAPA, DECLARE TIMI, and DAPA heart failure, the dapagliflozin was found to be nephroprotective and as well as cardioprotective. Evidence-based study dose adjustment in CKD, dapagliflozin 10 mg daily can be initiated up to EGFR 20 and not recommended with EGFR less than 20. It may continue if already tolerated, and for kidney and CV benefit. Although at such low EGFR, the glucose lowering effect is not there, but there is still cardioprotective and nephroprotective effect which is there. And for sitagliptin, the dose can be given in modified doses if the EGFR is more than 45. Holistic approach for patients with diabetes and CKD. Lifestyle approach includes a healthy diet, physical activity, smoking cessation, weight management. First line therapies, SGLT2 inhibitors if the EGFR is more than 20, metformin can be initiated if EGFR is more than 30. And then there is regular assessment of glycemia, albuminuria, blood pressure, cardiovascular risk, and lipids. GLP-1 receptor agonist can be added if needed to achieve individualized glycemic target, and other glucose lowering drugs, if needed to achieve individualized glycemic target, can be started. For blood pressure, RAS inhibitors at maximum tolerated dose should be initiated if there is hypertension. Then non-steroidal mineralocorticoid receptor agonist antagonist can be used if there is ACR is more than 30 and normal potassium. CCB and diuretic can be given if needed to achieve individualized blood pressure target, and steroidal mineralocorticoid receptor antagonist if needed for resistant hypertension if EGFR is more than 45. And moderate or high intensity statin can be used for to address the cardiovascular risk which is there with CKD. Antiplatelet agents for clinical ASCVD and ezetimibe PCSK9 inhibitors or eicosapentaethyl ester can be used if indicated based on ASCVD risk.
So, Dr. Suchitra, we will be talking a lot about diabetes and chronic kidney disease and how we can help our patients live longer, live better. So, to begin with, I'll begin with the first and the most important question: that what are those early signs and symptoms of CKD in individuals with diabetes?
So there, Mogensen's classification of CKD is there. The first stage is increase in GFR, the second stage is silent phase, third is microalbuminuria, fourth is macroalbuminuria, and fifth is end stage renal disease. So the earliest thing which we can see as clinician is presence of microalbuminuria. So routinely in every diabetes patient, we annually check for urinary ACR, albumin creat ratio.
So thank you so much, Dr. Suchitra, for a detailed answer, and that will, really set the ball rolling because if our physicians can diagnose CKD at an earlier stage, they will be able to pass on the benefits of lot of newer treatment advances at an early stage to the patients, and which will lead to a lot of better outcome, lot of good outcomes, and decreased morbidity and mortality as a result of chronic kidney disease in the patients. Because one of the earlier markers, as you highlighted, which we discussed, these earlier markers are actually a surrogate marker of a chronic cardiovascular disease in large number of patients. So if you are able to uh, tackle them early, diagnose them early, you can treat them early. So we move on to the next possible question, that is, how can diabetes management help prevent or slow the progression of chronic kidney disease? After all, the most important cause for the development as well as progression of chronic kidney disease is diabetes. And how can we manage our diabetes better so that that complication is prevented or its development is slowed down?
Across various trials, even in UKPDS, it was found that intensive glucose control is associated with decrease in risk of microvascular complication, decrease in risk of progression of CKD.
Thank you so much for your detailed answer. And, that really helps because we can, at the end of the day, remember that the chronic kidney disease, the most important factor which is leading to development of chronic kidney disease in people with diabetes is diabetes itself. The duration of diabetes, the severity of disease, the controlled or the uncontrolled disease, that makes a lot of difference. At the end of the day, we must remember that if we are able to help the sugar control in a better manner, the complications of diabetes are reduced. I always talk of the sugar control as almost like a principle of Alara, that is as low as reasonably achievable, which means that, if you can help the patients achieve a lower control without subjecting the patients to any hypoglycemia, without subjecting the patients to any undue side effects of medications, then the lower the better, right? And number of studies have shown that if you get an HbA1c less than 6.5% for the microvascular complication aspect, that is diabetic nephropathy, diabetic retinopathy, diabetic neuropathy, it is definitely better to have the better outcome with lower sugars. And chronic kidney disease is a microvascular complication, and we know that if you're able to control the blood glucose level very well at an earlier stage, the patients lead to a lot of good outcomes in the long run, the legacy effect that stays. So that's why the most important factor is the diabetes management. Coming to the next question, what are the recommended screenings as well as the tests which can detect chronic kidney disease in people with diabetes?
So annually, we should go for creatine assessment of creatinine and urinary albumin creat ratio. Other thing like cystatin C were also seen but not found to be very useful.
So thank you so much, Dr. Suchitra, for your answer. And that's very, very important. We cannot overemphasize this fact again that large number of patients with CKD unfortunately are diagnosed at the late stage. And one of the reasons why people are diagnosed at the late stage is because they have this fixed idea in their mind कि मेरा creatinine normal है, so everything is going to be normal, right? We want to make sure that it's not at the stage of an elevated creatinine where people are getting picked. It's not at the stage of a deteriorating EGFR where the people are picked. We want to pick those people early at the stage of diabetic nephropathy where their creatinine level may be normal, but the patient may be developing a microalbuminuria, which can actually be reversed with the newer and newer therapies that have come into picture, right? Because most of these therapies work on this concept where the decrease in intraglomerular pressure. That brings me to the next stage. Can you explain the concept of renal hyperfiltration and what is its role in the early stages of diabetic kidney disease?
Yeah, renal hyperfiltration is the earliest stage of CKD in diabetic patient, and it is mediated with TGF beta. But its inhibitors have not been found to be very effective in CKD progression in reducing the risk.
Thank you so much, Dr. Yadav, for your detailed answer. That really helps understand the pathophysiology of the development of diabetic nephropathy and how therapies which are targeting that pathophysiology help control the diabetic nephropathy at an earlier stage, help control the diabetic kidney disease at an earlier stage, and decrease its progression. And at this stage, we also want to talk about inflammatory pathways which contribute to the progression of both diabetes as well as chronic kidney disease. And are there any therapies which are targeted at particularly for this and address this interplay?
The various targeted therapy inhibiting the effect of TGF beta were seen, but they were not found to be clinically useful, like perfaninon and various nons were tried and they are under trial, but no benefit has been seen inhibiting these inflammatory pathways. Also, aldose reductase, which was there, sorbitol, pathway was also aldose reductase inhibitor have also been tried, but not found to be very useful.
So thank you so much, Dr. Suchitra, for your detailed answers, and we are very happy to listen to all of your detailed information about diabetes and chronic kidney disease. I'm sure our viewers will be more learned with all this information, and they will be able to help our patients treat in a better manner. So, thank you so much. And at this stage, I'd like to close this session and say a big thank you to all our listeners for helping us complete the 50 episodes of 4D 2.0 show, that is Detailed Discussion Dialogue of Indian Diabetes. This is your host, Dr. Sachin Mittal, signing off for current session, and hope to see you some other session soon. Till then,